Thanks, Connor. Good evening, everyone. And as Connor said, welcome to our Firefly Clinical Gold. It gives me great pleasure to see Sarah come along tonight on our screens and present on plantar fasciopathy in the elite sports person. I've known Sarah now for approximately 5 years. The first time we met was down in NUIG in Galway when she was in her final year. And one of the things that I remembered in that visit was that Sarah always asked really good questions. And in terms of getting answers, it's really about the quality of the question. So it really struck me that Sarah was inquisitive. She wanted to know more. And that kind of enthusiasm and desire to be the best version of herself has continued really over the last 5 years. And I've witnessed her develop in terms of her MSK skills, and recently then she completed her master's degree in sports and medicine exercise in the Ulster University, and with that I saw her elevate to another level in terms of how to take the evidence base, specifically around exercise prescription and how to add that to the rehabilitation of the patients that all of us see on a day-to-day basis. So it was really quite an easy task for me as the medical director in Firefly to reach out and ask Sarah to become a Firefly ambassador. She really does have the ability to treat complex pathologies at a high level now with custom-made foot orthoses and their prescriptions, and also Ritchie brace therapy. So Sarah, I'm delighted you're taking the time to share your knowledge with all of us tonight. So please press on and delight us.
Okay, so I will fire ahead with my presentation. Thank you for having me on, and also thank you for the challenge of presenting in 10 minutes. It was very hair pulling out kind of crack, but I definitely think, as you said, it's nuggets. So I'm just going to share my screen. Oh, and perfect. And go into this and share. So Martin, can you see that?
Yes, that is just loaded now. Yeah.
Brilliant. Okay. So, oh, perfect. Thanks. So, as Martin said previously, I'll be discussing distal or medial band plantar fasciopathy in elite athletes. So, I suppose I chose this case study as I found that it was incredibly interesting, not only because I suppose normally we think of calling it firstly plantar fasciitis instead of plantar fasciopathy, depending on where we studied or what the patient's presenting with. But I think as well as that, I don't think we consider plantar fasciopathy all the time in the more athletic population. I think we normally think of it more in kind of the sedentary population or older population. So I found it interesting. As well as that, it really opened the door for me to be involved as part of an MDT team within professional rugby, and I just found that really interesting, the different dynamics. So without that, I'm conscious of time here. So what I've decided to do is it's not just one case study. Again, the reason I chose this was I actually had 4 different rugby players being referred to me for the exact same injuries. So I've based what I'm saying off today off 4 different players. 3 were male, 1 was female, and they were also from 2 different clubs. So I'm very lucky to work with 2 professional clubs in the west of Ireland. Now, they were referred by the players' physiotherapists. So each player has their own physiotherapist, and that physiotherapist only covers about 7 players per team. And they were all backs positions. That's the position in rugby that does the most running. And they all really interestingly had similar foot posture. So we were looking at kind of pes cavus, subtle cavo varus foot types in the 4 players that I saw. So as I mentioned, for me, the elite MDT framework is so interesting. So basically you deal directly with the lead physiotherapist. So if you look at the first figure, the circle down at the bottom, you'll see that it's the athlete, the coaches, and then the physiotherapy lead. And from that physiotherapy lead, they are then the chat to the different practitioners, including the sports podiatrist. And this works really well. Again, if you look over then at the pyramid to the right, this works really well within the operations of this MDT. So at the bottom, you're ensuring that you've the shared values. So like that, we all know that a non-injured player is the best player. And we look at kind of injury preventions. Everyone's idea, everyone's expertise is valid. So you need to have everyone joined in together, and there's always room for improvements. That's your CPD and different attending different talks like this. Then expertise, that's where sports podiatry would come in. So we know that we have our own scope and our own expertise, and that's what we're bringing to this pyramid. And then operationally, you can see that there's constant reviews, there's constant changing and modifications, and I will go into this at the end. So like that, my job was being the sports podiatrist. So the referrals were really common. So they all were talking about cramping in the arch, low grade tenderness under the big toe joint, and pulling in the arch, a feel of pulling following running, and aching in the bottom of the foot after training. So it was all very similar like symptoms that they were kind of talking about. So again, with assessments, with elite players, it's really interesting because it's not just you and the player most of the time. Depending on the player, it'll be you, the physiotherapist, and the player. And as well as that, depending on the physiotherapist and players availability, you may be traveling to their high performance center, or they'll be coming to your clinic. It just depends. So you have to be able to move and willing and able to kind of travel. And like that, I did my full assessment. The little bits that I would notice that we look at the subtalar joint range of movement and midfoot range of movement, because remember it's a pes cavus foot type. So like that, there can be quite limited movement in the subtalar joint and midfoot. Go through kind of looking at the first MTP joint, you're looking at the movement. When you get to end range of dorsiflexion, the first MTP joint, is that plantar fascia kind of causing that little bit of pain? You're palpating the sesamoids and you're palpating that plantar flexed. You're looking at their plantar flex first ray for how much movement. Is it compliant or is it stiff? Then I would travel down through the plantar fascia. And I will speak a little bit more about this medial band or distal plantar fasciopathy I'm speaking about. But when they're chatting about this pain along the bottom or cramping, first thing I'll do is I'll start palpating that medial band of the plantar fascia while I'm dorsiflexing the first, while I'm not. And I'll also look at the insertional point, as we know that that can cause injuries. But is there pain while I'm not palpating at the end range of dorsiflexion? And also I'm looking at callus patterns. So do I see kind of a low gear toe off callus pattern, or possibly twisting of the hallux IPJ? And then I suppose I look at my weight bearing assessment. So things that I would have noticed in these players with these issues is that there'll be a positive JAX test, or like their stiffness and delay when I'm trying to dorsiflex the first as their weight bearing. I'll also, while I'm doing that, palpate the plantar fascia and see have I replicated the pain. And a lot of the time I will have. Now, they had a high supination resistance, because remember, supination resistance is not necessarily indicative of their foot type. So even though they have this pes cavus foot type, there is massive force going along the medial aspect of the foot, and that force is going to end up going through to the first. As I said, we're looking for that plantar flex first. So again, if you have a plantar flex first with huge amounts of force going through, there's going to be issues. You look at a Coleman's block, because again, if they're that pes cavus foot type, we want to know, is it coming from that more rigid forefoot, or is the rigidity or stiffness more in the rear foot? And again, that's going to change how you make your orthotic. Again, their foot posture, as I described, as pes cavus. During their functional assessments, you're going to see how that foot actually works while they're jumping, hopping, squatting, running, things like that. And on the gait, for this injury, I'm really focusing on from end stage of mid stance to toe off, because that's when we really see what happens when those peak plantar forces and how they affect propulsion. So again, common characteristics, you all know this, but again, we're looking at lack of shock absorption, a laterally deviated subtalar joint, stiffness in the midfoot, which reduces the MLA deformation, which would absorb shock, heel varus, plantar flex first ray, and normally a soft tissue ankle equinus. And again, this is really important because we think about their movement patterns. So we know that a pes cavus foot is linked to abnormal high pressure in both the rear foot and the forefoot. And we know these abnormal pressures are linked to foot posture. So a cavus foot has a greater peak eversion and abduction of the rear foot than a pes planovalgus foot type. And again, as I said earlier, there's going to be this lack of MLA deformation and therefore impaired shock attenuation anyway. So that's going to be a factor within all of your treatment. And then we also know that there's peak pressures in the fourth and fifth MTP joints compared to a pes planovalgus foot type. So that's just an interesting point if there's other symptoms. So again, I mentioned a plantar flexed first ray. That can be compliant or stiff, but it leads to this early ground reaction force through the first MTP joint. And that can prevent this high gear toe off, which can cause tension through the medial band of the plantar fascia. It also can cause these kind of sesamoid like injuries or sesamoid injuries, because they're also, the sesamoids are attachment points for the plantar fascia as well as other muscles, and you've now kind of displaced them and made them more prominent and given them more ground reaction force. And remember, sesamoids are really important for the mechanical ability of transferring ground reaction force through to the first met head. So now you've kind of started changing the way force will be able to move through. So distal plantar fasciopathy, again, we're looking at the non-weight bearing area of the plantar fascia. So it's much higher up. It's not those heel insertion points that we normally see. And it's normally in the medial band of the plantar fascia. So it's kind of that nearly that turn off up into the first. And it's because that, and some of those fibers go through the sesamoids and into the base of the hallux. So they're subjected to the greatest tensile loads of the plantar fascia. So, and it's also because the first MTP joint is subjected to ground reaction force. And when the first MTP joint has ground reaction force, that medial band increases its tensile load. So the more ground reaction force in the first MTP joint, the more ground reaction or the more tensile load going through the medial band of the plantar fascia. And its main function is to prevent dorsiflexion of that first ray. So think how many joints along that first ray compared to the lateral border that it needs to try and control. So, and it also helps elongate that MLA. So that nice shape of the MLA that we want for orthotic therapy is coming from this medial band. So again, the greatest load that it exhibits, so it exhibits all this load, but the greatest load moment is just before heel off. So that's why during gait, that's what I'm looking for. And that's where we can see that repetitive injury start to happen. So with my orthotic prescription, I mean, anytime I'm prescribing orthotics, I ensure that I have very clear objectives, and then everything else comes from there. So my main objective first is to reduce ground reaction force at the first MTP joint. Through that, I'm going to reduce as well tensile force going through the medial band, causing the injury. It is a pes cavus foot type, so if I can provide shock attenuation and shock absorption, that is always important. And then I'm going to try and accommodate football boots and trainers. So in elite sport, they're lucky that, again, they're able to get the 2 or 3 pairs that they need depending on the footwear. So they normally get 2 different pairs, one for their training shoes or their runners and one for their football boots, because again, they're going to be very different designs, seeing as you're so limited in the space within the football boots. So I'll ensure there's shock absorbing materials and additions. Now that's much easier when we're talking about the device within the trainer, because you're able to add, you know, an infill, you're able to make the orthotic wider to dissipate pressure better. You know, there's different things you're able to do. Whereas in the football boot, you really just have maybe a more cushioning top cover. What I'll also do is I'll use a reverse Morton's extension, which is like a 2 to 5 Met bar, but I'll start it back at the cuboid. The reason behind this is if you just look at the photo here, it's Kevin Kirby's work where he has this laterally deviated subtalar joint. And what I'm trying to achieve is I'm trying to create an earlier and more controlled pronation moment. Because in order to get them off that lateral border, but also not to load that first too quickly, I'm going to try and pronate that foot earlier. And as I said, more controlled. So what I'll do is I will use a reverse Morton's extension, but start it back at the cuboid. And sometimes I'll even have it with a varus wedge just to try and really pronate that midfoot as best we can. I'll also may introduce forefoot valgus posting. So for the same reasons, again, I really want to pronate that foot, because we know that with a pes cavus foot type, sometimes what you'll see is they'll be laterally on the lateral border of the foot for majority of the time. And at the very last second, they'll have this whip in of pronation. So they are still pronating, just very late and with this high ground reaction force because of the whip. So if we can slow it down and control it better, it just means it's more controlled and they can achieve high gear toe off. So I'll also then try and create that pronation moment of force within the shell. As I said, creating that pronation moment of force can start farther back. So you can also use a valgus rear foot post, or you can use different kind of additions or modifications to try and push them in. I normally will use a heel lift. Again, if I can help the sagittal plane, it's going to make things much easier, because majority of pes cavus feet don't have movement in the transverse plane. So what we want to do is we want to get them moving as efficiently as possible through the sagittal plane. So by adding a heel lift or by using a first met cutout, that can help achieve that. And the last thing then is cast dressing. So with this, again, pes cavus foot type, you don't want anything on the right or on the left-hand side of that line that Kevin Kirby's drawn here. You want it all on the right-hand side, not the left-hand side. So like that, I'll ensure that I pull the shell away from the MLA with the cast dressing. I suppose my main point with my orthotic prescription, even though it sounds like I'm doing a lot, is that in these athletes, their biomechanics are normally very sound, and it's more just little nudges because of the amount of load going through certain structures. So really everything is just a little nudge in one direction or the other, just to try and offload certain areas. And last thing is further management. You have highly qualified strength and conditioning and physio. What I'm normally doing is I'm indicating slight modifications or slight additions to movement that I want them to do, and I'm just explaining why I'm adding that. And normally it's to do with the intrinsic foot muscles or getting that high gear toe off through their plyometrics and their calf work and things. Footwear advice, again, you have to figure out whether that player is running yet. So a lot of them, if they're injured, they might not be running yet. So they might be in runners a lot more, where they're doing kind of pitch runs within a runner, not yet a football boot. If they get to the football boot, what you may be looking at, especially if they have a tender kind of first MTP joint, you might remove the moldy, use an angle grinder or something to grind down the moldy underneath that painful area. And the last thing, and this is the thing that I learned, I suppose, after doing all this, is with fitting and reviews, all devices are on rush. So everything's on rush. The turnaround time with these players is very different. You're in constant contact with the physios. It could be any time, day or night. It's just a whole nother world. And I suppose we're also looking at, there's a much higher speed of review dates. So again, because they're loading so much quicker, they might break in the insoles a lot quicker because they might have 2 training sessions that day. So everything is kind of on a go fast. So and there are my references for further reading. Whew. So Martin, how did I do?
Very, very good, Sarah. You were on a turbo boost there just to get through all of that.
I hope
because
there's
you did have
questions
quite a
and
lot of
discussion.
text on your
Sorry.
slides. Yeah, absolutely. Yeah, I mean, for those that want to stay on, please do so, and we can ask a few questions. So Sarah, I'm going to ask you a few questions just to challenge you, of course.
Yeah, of course.
The first one is that, well, is more of an observation in that you chose to go for the sort of subtle cavo varus or pes cavus foot type, whereas in most cases, when we think of plantar fasciopathy, and of course most people still call it plantar fasciitis, you would normally associate that with the more pes planovalgus foot type. So I like that you went to the more challenging foot type to treat. So that was good. Yeah. The thing that really struck me was you focused a lot in terms of the prescription about the deviated subtalar joint axis in terms of it being lateral. And I thought that was a very good point to kind of pass on to the audience in terms of, what you were doing to try and load the lateral side of the foot that would impart a pronation moment of force. You mentioned cast dressing, so I'm going to pick up on that. And you talked about pulling away the MLA from the foot. Now, what does that actually mean? So tell me what you would do in terms of cast dressing on the medial side of the foot to pull that orthotic shell away from the medial side of the foot.
Well, now that I can breathe a little bit, so basically, as I probably repeated myself about 10 times, with this pes cavus foot type, because of the lack of shock attenuation, you have these certain points. So like the heel, the fifth MTP joint and the first MTP joint, and they have these high peak plantar pressures, which is normally why they can't function, I suppose, ideally, or the way they should. So what we want to try and do with this foot is create more, I suppose, more contact area. And the best way that we naturally shock attenuate and become a mobile adapter is pronating. So my main aim, especially if the foot will let me, is to make the foot pronate. Now, if you have all of these things on the lateral aspect of the device to create a pronation moment of force, the worst thing you can do is have a shell that's too high, because you are having all of these additions and different things to pronate the foot. And then if the shell comes up too high, what you're then doing is now you've the foot stuck in the middle, and it's now getting hit from both sides, and you're going to get tolerance issues, and you could get further injuries, and you're not going to achieve anything that you've tried to do on the lateral aspect.
Yeah, absolutely. And I mean, a way of doing that is then, I mean, two ways. One is you put a first ray cutout in, so you actually take away the shell completely. And the other is to put the maximum cast dressing on the medial side.
Yeah, and there's for and against them, because like that, if you're really struggling for fit into a football boot, a first rate cutout can be your best friend. However, I also find that if we're really trying to control, now again, there's definitely contradicting views on this, but just in my own head, what makes sense is that I want to continue that shell through the MLA, because I want to try and offload that plantar flex first as best I can. So what I'll do is I'll ask for at cast dressing, I'll ask for moderate or even maximum at the MLA. So what that means is that they are pulling the shell a couple of millimeters away from the foot, and that allows for that foot to pronate comfortably.
Yeah, maybe just for the benefit again of the audience, cast dressing is essentially what we do in a lab to allow normal tissue spread. So if you can imagine a scan of the foot or a cast of the foot is taken non-weight bearing. So what we have to do is determine how much will the tissue spread on weight bearing. And the cast dressing is what allows that soft tissue spread. And the lab standard would be minimum, but you can, of course, go for skin. And what you mentioned there was moderate or maximum. And there's probably about 1 to 1.5 millimeter between each of those scales. So yeah, in this particular case with the distal plantar fasciopathy, I totally understand why you want to continue the MLA shell, because again, you're having contact with the foot and therefore dissipating forces over the shell of the orthotic device.
Yeah, and as well as that, as you described earlier, it's normally the pes planovalgus foot type that we're discussing the high ground reaction force through the first. And in most cases, what we're trying to do is reduce the pronation moment of force so that we can reduce the ground reaction force through the first, which is causing tensile load through that medial band of the plantar fascia. So while we want to pronate the foot, I want to continue that shell, because I don't nearly want to pronate it too much that we're now causing the injury for a different reason. So it's kind of juggling.
Yeah, I mean, it is an interesting kind of concept, because we're talking about two different foot postures that potentially create the same type of pathology, and therefore what it really means is that it is multivariate and it's complex. And again, that's why you're looking at complex, I suppose, prescription writing, but also looking at footwear advice. You're looking at the physios being involved. You're looking at strength and conditioning coaches, and all of that together that combines as a sort of an overall picture to treat them. What do you feel about treating with something like shockwave in these cases as well, other modalities?
I suppose the issue with shockwave is they can't really, there's definitely days that I just know in speaking to the physios that they don't really use shockwave as much in this case that I've experienced, due to the they have to take a couple of days off with that collagen repair following shockwave. And they, as I said, they have the strength and conditioning coaches that are with them every single day that are able to provide those loading protocols and you know, that shockwave can do. So I think that's the way they kind of do it. And I suppose when it comes to that area, I'm not really, I don't feel like it's in my, I don't know enough about shockwave that I would be able to give an opinion towards it. But I suppose what I'd really work with them is kind of describing different intrinsic foot muscle work that they could incorporate, and just explaining the importance of the high gear toe off in this case. And because there's so much tensile load going through the medial band of the plantar fascia that's caused the issue. So if we can get an eccentric load going through it, that can really help with symptom relief, but it can also get rid of the injury itself.
Okay, excellent. Sarah, there's a couple of questions that came in from viewers that are on the chat. First one is from Jenny Letran. Hope I've pronounced that correctly, Jenny. And it says, have you got a photo stroke diagram of the RME back to the cuboid? I imagine that is the reverse Morton's extension back to the cuboid.
We definitely have reverse Morton's extension on the Firefly website on additions. So it's literally just asking for that to come back further. It's also known as contralateral wedging. And also I would sometimes wedge the reverse Morton's extension, but I just didn't I didn't have the time to add that in. But what we can do is I'm sure we can draw something in for you. Yeah, we can certainly draw something in for you, but basically picture 2 to 5 Met bar that's normally goes underneath the 2nd to 5th Met heads, and just bring it all the way back as far as the cuboid, and then bevel it down so that it's about 0 and down the midline of the foot, because obviously that would be a little bit uncomfortable.
Yeah, you did mention, I mean, essentially it's a slight valgus post, you could nearly say, on the shell. There's another question in from Andrew Schilling, and he has asked, should we test how much the rear foot can evert? Can we introduce too much pronation moments?
Absolutely. And this is kind of where, again, sorry, I rushed through it, but this is where I'll spend a lot of time assessing subtalar joint movement non-weight bearing. And I also will assess it weight bearing. So I'll get them standing and seeing how much they can evert and invert their calc, because like that, really good question. If it's a very rigid, kind of mid or rear foot, if you give too much, say like valgus rear foot wedge or anything like that, you can definitely cause tolerance issues. Now, as I said, in these players, I really rarely introduce any rear foot valgus posting. One of the reasons is that I feel it might be a little bit too much, because their issue is really a forefoot issue that they're coming into me with. However, I have seen, I suppose I have definitely seen too much rear foot valgus be introduced and cause issues. So yeah, I would always err on the side of caution. I would assess, make sure I have enough movement to actually change the functional load, and then go from there. If I'm ever doing a rear foot valgus post, it's never more than 3 degrees, and that would be once a year, very, very rarely, because there's other ways you can introduce it.
Maybe just, I mean, I could add something to this, Sarah, in the sense that when you're talking about the subtle cubovarus foot type, quite often, really that sort of rear foot to forefoot alignment, you just post the calcaneal vertical.
Yeah, definitely.
And what you then do is you might add a lateral flange, you might add a lateral Kirby skive, and the key thing again is that 3 millimeter heel lift that's really focusing on the sagittal plane.
Yeah.
And what I think is, if you can think of the wet footprint test for the subtle cubovarus foot type, you get that point of contact across the forefoot and on the heel, but you actually don't get any contact on the lateral border. And when you put the orthotic shell in that is made to that person's unique anatomy, you get a contact from the rear foot to forefoot that spreads load. And those other little things that I talked about, the Kirby side on the lateral side, the lateral flange, those all induce moments of pronation. Rather than thinking about inducing an alignment change. Now, that's going to happen more if you use a Ritchie brace because you've joint coupling to the lower leg, but not in orthotic therapy. Would you agree with that?
Yeah, no, I definitely agree with it. As well as that, as I said, a lot of these athletes, like, this is like a low grade injury, or it's just an injury that's annoying them or aching or cramping. So I am so careful that I don't want to change anything else. So I use the word nudging, and physios seem to love it, that I'm like, oh, I'm only nudging things. I'm only changing the timing and changing the amount of load. I don't want to change much else.
Well,
like
well,
they
well,
are a
I think
five-star player.
that's a beautiful thing to bring up, because what you're doing there is that when you're dealing with other professionals, sometimes we have a different terminology.
Yeah.
And just finding the language that your colleagues use and being able to slip into that is important and pretty key. Another couple of questions here, Sarah. This one's from Claire Rooney, and really good question too. How do you cope with providing a set of orthotics for performance football boots and the athlete's running shoes that will probably have a totally different material composition? Question is then, do you have to analyze the athlete in both sets of shoes and provide an orthotic specifically for shoes they will be using?
Yeah, Claire, definitely. I would, they'd always get two sets, because there's just, you're so limited within the football boot as to what you can achieve. Everything's either 50% or you can't do it, or you're half doing it, or, the only thing I suppose is when they're in the boots, there's a lot more forefoot loading. So I suppose that's what I would focus more on. And then with the runners, I suppose the world's my oyster. I'm able to kind of do a lot more. I'm also able to manipulate what runners they are wearing and when they're wearing them and things like that. So I would be doing two completely different devices. And as I said, like, it is lucky that when you're within that realm, I suppose money isn't as much of a problem. So yeah, they're covered by insurance.
Yeah, I mean, I'm going to probably say that what you're doing in terms of your approach to practice here is probably what we do in our clinical practice, in that a lot of the patients receive two sets of orthoses. And one is usually some type of sport device. It could be a low profile sport, which would be one of my favorites. Again, I want the devices to be low bulk. So, I'll go low profile sport, but I also go for a dress device. And what I'm trying to do is to maximize the opportunity for the person to use these medical devices. So yeah, totally agree with that, Sarah. And it's the same, with, I suppose, nearly any, sport. It doesn't have to be an elite level, but you can design greater, bulk in terms of, the ground reaction against the orthotic if you've got a bigger shoe compared to like a soccer boot or, some sort of slimline footwear. Yeah.
The other point you made, Claire, that was brilliant, is that, yeah, I will get video analysis of both them running in boots, and then I'm able to do my own video analysis of them running in runners. So yeah, it's definitely important for you to be able to see both. So I won't do the video analysis of them in boots. It's normally just done by the physio when they're out training. And then they'll do a straight line run, and they might do just a couple of S runs just to have a good idea of what's going on.
I mean, the key thing again, of course, is that for us as podiatrists, the difficult thing is that when we do, say, video gait analysis, it's giving us a certain amount of information, but obviously we can't measure load. And really what you're looking for is, so what you're looking for is telltale signs as to, how they're moving, but most importantly, is it comfortable?
Yeah, and callus patterns I find brilliant.
Here, yeah, and they're on the feet, so it's easy, isn't it?
Yeah.
Yeah, there's a question in from Mike Coates here, and there's two questions from him. The first is, do you mark the subtalar joint axis on the foot to capture on the scan or on the eye scan or on the cast? So do you actually, no?
No, I actually don't mark it on. That, like, I definitely did at the beginning, just to try and really get my mind around it. I'm more of a practical learner myself, so that's the best way that I could start picturing it and getting an idea. But I don't anymore. So I definitely did, but just not as much anymore. I suppose now I'm just able to say exactly where I want my different additions and modifications, where I want them seated, and I know the girls in the lab know what I want so well at this stage, that I know that I'm getting the prescription and everything that I need. So it's definitely, you know, I wouldn't say trial and error. I would definitely say err on the side of caution. You can definitely draw the line and show exactly where you want your different additions and posts, no problem. And then after a while,
I think you're being very humble here, Sarah. But you know, it's just because you're experienced in it that you can actually palpate it and you can find the subtalar joint axis. But certainly in the early days, you would have marked it. I remember that.
yeah.
The other part of the question from Mike there was, have you ever used a less rigid shell to allow flex to facilitate a pronation moment in this type of case? Brackets, I'm thinking of 3D printing and the possibilities of shell tuning. So I think what Mike means by shell tuning is that with 3D printing, you can increase or decrease
Stiffness in certain areas.
Yes, the stiffness characteristics of the shell. So you could have a more stiff lateral component and then a more flexible medial component.
Yeah, so I suppose I am doing that already. Thanks for the question. I suppose I'm doing that already because I'm lessening the MLA height of the shell, you automatically reduce the stiffness of the shell, as Martin's taught me before. It's physics. That's the answer I got. And then as well as that, what I'm doing is I'm doing a higher cast dressing on the lateral aspect, so that will make it more stiffer. Obviously, if I would be able to do something like that, that would be really cool. Because yeah, definitely. Or I have used a semi-flex shell in some cases where I know, now not so much in an athlete because it but more along the lines of if someone was standing for long periods of day with a pes cavus foot and I wanted to do a pour on infill to provide more I suppose more shock attenuation, then I'll use a semi-flex shell. But apart from that, I really stick with my like XT Sprint carbon fiber shells for boots, but I just manipulate the cast dressing to help with the stiffness of the device.
Okay, you just suddenly threw in XT Sprint, so we're going to now have to talk
Sorry,
about
yeah,
XT
I know.
Sprint.
I was looking at you hoping you'd explain it.
So probably, you know, in terms of orthotic shell design, the most common would be polypropylene, and that's been the mainstay of podiatric interventions for the past 30 years. One of the big changes is material technology, and XT Sprint is a carboplastic. And essentially, it's a plastic like polypropylene that has been impregnated with carbon. The beauty of XT Sprint is that it's very thin, and you can get it in different shell thicknesses based on body weight. But the key thing that we like is that it sort of flexes in the sagittal plane, but it doesn't really move an awful lot in the frontal or transverse plane. So it's very good for explosive, fast running in a unilateral direction. And that makes me think of the rugby back player who has to explode very fast, pretty quick. So it probably works quite well for that. I also find it really good for anybody that's doing a lot of long distance running. So I just mentioned that as you brought up XT Sprint.
Yeah.
I just want to, there's another question here from Claire. So are you influencing the person's purchase of running shoes too, Sarah? Is it difficult when you're presented with a shoe that someone has purchased without professional input?
So this one is really interesting as well. Thank you, Claire. Because a lot of the players I'm dealing with are sponsored by Adidas. So they have to be wearing Adidas while they are training, while they're at the gym. Like the only time they don't have to wear it is if they're out casually. So that's not when they're putting load through and you don't care as much as what they wear when they're just, you know, at home or whichever. So it is that little bit more difficult, but I think that they are so well monitored that you know, you can, I'm not finding any difficulty giving footwear advice as long as it's within their sponsorship deals. As well as that, I've found that the S&C coaches are actually asking, so when would be a good time for them to do exercises barefoot, or when would be a good time for them to be wearing footwear? So that's a whole nother kind of side of things that I didn't even think about. So there is difficulties to it in the likes of sponsorship and things, but then there's also you know, because they're monitored so much, you'll actually be able to pick and choose what activity they do and what footwear when they do listen.
if it wasn't somebody that was an elite sports person and had a sponsorship deal with Adidas, would you still give advice on specifically what type of runner would be beneficial to them?
Yeah, I definitely would. And depending on their activity and things, like I know for this pathology that Brooks Ghost 13 works really, really well because of the high heel drop and the thick midsole and the forefoot rocker. But these players aren't doing a lot of road running or long distance running. So it's
Well, I'm sort of talking
not
about
really
just say the general public. I mean,
important. So then
we're
you're looking
very,
more on gym.
yeah, we're probably quite fortunate in that John Delaney, who
Yeah,
qualified
we have a
Saviour
next door.
Shoe. So we have a running shoe store which is next to our clinical business and next door to the lab. And John is a podiatrist who has really, I suppose, specialized in learning about running footwear. And really we should get him on and do a little presentation here, because John is amazing in terms of choosing the right shoe for the right person. Essentially, he uses running shoes as medical devices, and even things like how to tie the laces differently changes various characteristics. So, I mean, that we're lucky in the sense that we can refer people to him, and he can advise a whole lot of nuances around running shoes that we don't normally have access to.
Yeah, because Martin, we went in, you and I, and we had about an hour and a half with them, and our minds were blown. We're like, oh my God, if we
Yeah,
knew all this, we wouldn't
yeah,
have to maybe
totally.
add as much of a heel lift, or our device could be that
Yeah.
bit more wide at the forefoot.
And at that
there's all
time,
these
I
different
saw that
things.
as being clinical gold, sir. And I said, we got to get that. We got to get that out to the podiatric profession because it was
Yeah.
so good. There is another question here that's come in from Callum, and Callum is just asking, could you explain what high gear push off is?
Oh yeah, of course. Yeah, because I was really new to that as well, as a term. And once I've learned it, it's changed my practice so much. So a high gear toe off is where you are, so end stage of mid stance, you have all your kind of ground reaction force through the first and a little bit of the second MTP joint. And what it means is that as you're propulsing, the main transfer of force is through the first MTP joint. Okay, there's a few reasons why this is really important. One is that it activates windlass. It's the most efficient in the way of like the sesamoids and the different muscles that come through. So you get this nice eccentric tension through them, which is, by not getting that eccentric load, is why we're getting this injury in the first place. And then as well as that, if you're gearing off low gear, it means that you're gearing off the left. It's not really made to take the force as the big toe is. And so what you look is, you'll see kind of different synovitis, capsulitis, different injuries of those lesser met heads. The final part then is, if you're doing a high gear toe off, you really have that peroneal muscle coming around, slinging underneath the cuboid and into the base of the first, and it just provides huge stability at the rear foot as well. So that's why we really try and get people to do that high gear toe off.
Yeah, I think maybe we'll finish with just a little comment, Sarah. Today we did a military training with a lot of the regional rehabilitation units around the UK, and
a couple hours
these
ago.
are all Band 7, Band 8 podiatrists working in these MDT teams, which is multidisciplinary teams. And one of the things we really talked about was going back to the principles that I would have learned a long time ago. And there's other people in this, audience will go, oh yeah, I remember that, which was the biophysical criteria for normalcy. And, the first principle of orthopedics is about putting everything where it should be. And, if you're looking at a pes cavus foot type, or you're looking at a very sort of pes plano valgus foot type, a lot of the time as podiatrists, we're trying to think, well, where should that foot be relative to the leg? And the biophysical criteria, it's taken a little bit of stick over the years because it was created by Roots and his colleagues. But yet it's still the basis of what we're attempting to do to offload certain structures that become injured. Would you kind of agree with that? Do you think that's kind of what we're doing? Even though we're talking a lot about loading, we're still trying to think, well, where should the foot be? How do we offload this? How do we offload that?
Yeah, I mean, I think it's really important to remember that the foot was created it will have a most efficient pathway. Now that's not necessarily perfect alignment, and that's where kind of the foot morphology theory kind of got its stick, but it definitely has a certain pathway that's going to be more efficient. And what we do find is that when it's moving slightly different to that person's efficient pathway, we'll see certain areas, joints, tendons become overloaded and therefore get injured. So I suppose what I do myself is I look at kind of sagittal plane theory, as we spoke about, tissue stress theory, but there's definitely still that little bit of thinking about, okay, if we change the way this foot functioned, what are we changing? Again, we know we're changing forces and things, but we know there's also a change along the alignment as well. So I don't think we can throw it completely out yet, but I just think it's important that we include the newer kind of tissue stress and things along with it.
I still think it's in there because we're talking a lot about the prescription writing and the production of medical devices, and a lot of how they're manufactured and designed is still using some of the foot morphology.
Yeah, sure. We still cast and subtalar or neutral.
Yes. Yeah, so we're still evolving the concept. Sarah, listen, thank you very, very much, and that was really, really good, and it got us really talking and thinking. And once again, thank you, and thank you for everyone to give up your time and join us tonight. And please don't hesitate. If you have any further questions, you can send them in to us. I just think one's popped up here. Let me see. Okay, last question, then we're going to leave. Hi, Sarah. What was the name of the running shoes you mentioned that is good for the pes cavus foot type?
Well, just make sure. Well, I better make sure to say that there are a few, but
you mentioned the Brooks.
Yeah, but the one that I'm really biased towards is the Brooks Ghost. So normally what I'll do is I will have a list of about 4 that I'll give patients to ensure that they're trying for comfort and to try and remove my own bias, because I know I'm downright biased for Brooks runners. But yeah, it was the Brooks Ghost 13 that I find in neutral that I find brilliant for a pes cavus foot, personally.
Okay, thank you very much. Okay, everyone, thanks for attending, and don't hesitate if you have any questions to just shout, and we're very keen to help everybody. So have a good night, and thank you very much. Okay.
Thank you for having me.
Bye, Connor.
Thank you. Thanks for your time.